Aortic stenosis is the most common heart valve problem, and what it does is it clogs the aortic valve, which is the outflow of the heart. And so when it becomes severe, then the heart cannot increase its output, and that means you begin getting symptoms of dizziness or angina or windedness or congestive heart failure. As soon as someone has symptoms that are associated with this severe aortic stenosis, it's a very, very risky problem to have. And the good thing is that intervening upon it and replacing the valve dramatically cuts the mortality, as well as makes people feel better. So people who have severe aortic stenosis at 2 years have about a 50% mortality once they develop symptoms, which is really a worse outcome than most cancers even. But when you're able to replace the valve either surgically or through catheter-based interventions, you can cut that risk almost in half. Originally, we used this technique called TAVR, or transcatheter aortic valve replacement, in patients who are too high risk to have surgery or were inoperable at all. And that opened an avenue of treatment for that segment of people who just couldn't have a treatment available to them. The procedure is much less invasive. It's done through catheters that are placed either in the arm arteries or the leg arteries, or sometimes directly through the chest, although that's much less common now. When we're able to go through leg arteries or arm arteries, the recovery is dramatically quicker. But it does entail a lot of interaction with other doctors because the planning of this kind of procedure is quite complex. So it requires us to interact with surgeons, with imaging cardiologists, and with referring general cardiologists to make certain that we find the best treatment for a specific patient. Because sometimes surgery is better, and sometimes transcatheter methods are better. But working together as a team really allows us to pick those people who are going to do better with whichever specific treatment we choose with the patient.